I welcome all the members who actually joined and taking time to go through the ECHO project. To emphasize again, the ECHO project is mainly run in a way that we present cases that we see in our facilities, in our institutions, and we share them. And basically, if we can all get to a standardized care and according to the Liver Society guidelines, we can help a lot of the patients who have hepatitis B. Okay, so this is again an educational program. We want most of you to actually call and share, and if you have any questions, keep it as interactive as possible. So today's objectives will be to describe the new and emerging therapies for hepatitis B and how they actually fit into the clinical algorithm and how we can manage them and how we can treat these patients. We're also going to figure out how and when to actually send these patients to a specialist care, or can you manage them at your own practice. So we've already talked about Yuen Lee. Again, as a recap, this is a 28-year-old woman who is planning to get pregnant. She was born in the United States, and her parents emigrated from Taiwan 2 years before her birth. When she was screened for hepatitis B, she was actually surface antigen positive, hepatitis B core antibody positive, which again goes with the prior infection. And she doesn't have a hepatitis B surface antibody. When she completed all the other serologies, the IgM core antibody was negative, which says that this is a chronic hepatitis B. She was E antigen positive, E antibody negative. Hepatitis B DNA is about 500,000 international units, and her ALT is completely normal. So if you recap from the previous slides, in the natural history, she is in a phase which is called immunotolerant phase. So this is a patient who has very high viral load, but her liver enzymes are normal. So what do we do in this case? Okay, should we treat? Should we wait? What do we do? So I think you'll all get a little bit of information after we complete the management aspect of hepatitis B in this talk today. So before we talk about treatment, one of the things that is foremost of importance is hepatitis B is preventable. Okay, there are several viruses which we cannot prevent. Okay, but hepatitis A and hepatitis B, these are completely vaccine preventable diseases. For hepatitis B, if you're choosing to give a vaccine, it's a three-dose schedule. It's typically given on 0, 1 month, and 6 months. There is now a better vaccine which is more immunogenic, which is given as a 2-dose, and it's given at 0 and 1 month. So if you find patients, or if you have somebody where you think that she may not come back for the 3rd dose at the end of 6 months, you can actually choose this 2-dose regimen, and that's pretty good. Now, when you think about hepatitis B, again, the most commonest cause for liver cancer worldwide is hepatitis B, just because hepatitis B is very highly prevalent. So this is actually one of the vaccine preventable cancer as well. So if you give vaccine to a susceptible individual and that person doesn't develop hepatitis B, you can actually save him from getting liver cancer. So the typical next question that you may have is when to refer a patient to a specialist. When do you refer them to a gastroenterologist, an infectious disease doctor, or to a hepatologist? So again, depending on where you work, you can actually choose to manage some of these patients at your own clinic. And again, if you're comfortable managing patients with liver disease, hepatitis B, given the ease of the treatment, these patients can be managed even in your own clinical practice. So when you're considering treatment, we need to think about whether the patient has immunoactive disease. This is a patient with E antigen positive or negative. But when you choose to treat, we are actually thinking of decreasing their liver-related complications. And even when you decide that the patient is not going to be on treatment, or if the patient doesn't agree because she's planning to get pregnant, or she doesn't have insurance and she's not ready to commit to a lifelong course, again, these patients, instead of being left without any monitoring, these patients should get regular screening with labs and with ultrasounds, okay? Remember, liver cancer can happen anytime, even without the development of cirrhosis. So when you think of starting a treatment for hepatitis B patient like Miss UN, and again, she's in the immunotolerant phase, the goals will be, again, ideally it is to improve survival and improve the quality of life. You don't want to start treatment without that as main purpose. We do want to prevent the liver disease from progressing and from preventing liver cancer. If it's a woman like our patient Miss UN, we want to prevent the mother-to-child transmission. We don't want her offspring, her kids, to actually develop hepatitis B. And we want to prevent hepatitis B reactivation, which typically happens in the postpartum period, or when the patient gets immunosuppression from chemotherapy and other things. And again, some of the other factors that we actually plug in is to prevent hepatitis B related manifestations, which are extrahepatic. Okay, so glomerulonephritis, renal failure, polyarteritis nodosa. There are several extrahepatic manifestations that are linked to hepatitis B, and you treat hepatitis B, those manifestations get better. Clearly, when we start treatment, we want to see that the viral load is suppressed. We want to see that the ALT, which is a liver enzyme, that normalizes. And ideally speaking, if the patient has E antigen positive condition, that has to be lost, and the patient develops seroconversion to E antibody positivity. If the patient is E antigen negative, we cannot follow envelope antigen anymore, so therefore we look for surface antigen loss and surface antigen seroconversion. All of you with me so far? Okay. So who should be treated? Why are we even talking about why only some patients should be treated and some may not require treatment? So let's go to the first one. Patients who must be treated are the ones who actually have immunoactive phase, where the hepatitis B DNA is causing liver inflammation. Although liver enzymes are not a good surrogate for liver inflammation, if the ALT is elevated, that's a surrogate marker or a biomarker that there may be inflammation going on in the liver. And if the patient has progressive risk for fibrosis, that is a patient who will require treatment, because if left alone without treatment, that patient may develop liver complications. So therefore, when we think about treatment, this is a must-treat group. Anyone with cirrhosis or liver cancer with any level of hepatitis B DNA, these patients should get treated. Again, the reason is when you are cirrhotic, your liver function is already compromised. If a flare has to happen, that patient will actually succumb to the liver failure due to hepatitis B reactivation. Now, in the other scenarios, in an E antigen positive patient, if the hepatitis B DNA is more than 20,000, if the patient also has surrogate markers of inflammation like ALT is elevated and the fibroscan shows that there is worsening of fibrosis, that patient needs to be treated. In E antigen negative patients, remember, we talked about this, since this not being the wild type virus and it's a mutant virus, you actually can see liver complications at much lower levels of the virus. So even at 2,000, if the patient has elevated liver enzymes or risk for fibrosis, this patient also will qualify for treatment. Now, when do you consider treating? This is not a must group, but this is a patient where you can consider treatment. Is, again, like our patient in the immunotolerant phase. If the patient is over 30 years, and I mentioned this in my previous talk, if the patient is African American, Or if the patient is a male, they tend to have higher risk for HCC, so that patient should be treated. If there is family history of HCC, again, or extrahepatic manifestations, our patient UN had an uncle who had passed away from liver cancer. So again, that family history will be very important because she probably has the same carcinogenic variant of hepatitis B, and therefore that actually warrants a treatment. And what we didn't have in our patient UN is assessment of a fibroscan, and I think that should be the next step. And if that shows that the fibroscan scores are getting worse as you're monitoring this patient, advancing fibrosis is one of the indications that you should consider treating that patient. So this is sort of like an algorithm to tell you, if you look at the top subject line, this is hepatitis B treatment recommendations, especially in e antigen positive patients, okay? So if the DNA is more than 20,000, and again, you see that DNA is more than 20,000 in all scenarios, okay? But the only thing that is different in all three scenarios is the first row or the first schema, the ALT is normal. This is like our patient with our patient UN in the immunotolerant phase. So if you see that that patient need not get treatment right away, we monitor their ALT. This is in the blue column at the bottom of the recommendations. So you basically match the purple, the blue, and the gray according to the columns you're seeing. So this patient need not get treated right away, but again, if the patient has family history, we're treating. So again, I think UN, in my opinion, should get a fibroscan, and we should consider treatment of Miss UN. Now the second scenario is when the ALT is in between. It's upper limit of normal, but it's less than twice the upper normal. So in this patient may be at the at the state of seroconversion. So we actually pay close attention to this patient and we monitor them with liver enzymes more periodically. Typically every 3 months is enough, but depending on the ALT. Okay, we need to exclude all the other causes of elevated liver enzymes. Remember, my patient in the last module also had fatty liver. And if the patient is drinking and if the patient has other causes, we need to counsel them regarding those. So these patients should be counseled, and if it's only due to hepatitis B, again, these patients may qualify for treatment. Now, if the ALT is twice the upper limit of normal and the DNA is 2,000 to 20,000, this again can represent seroconversion, and these patients also should be monitored closely. But typically when the ALT is twice the upper limit of normal, you look at the purple column. Typically you want to treat this patient, and treatment with the antivirals is really easy. And this can be done at your own clinical practices. Now, this is the same kind of algorithm, but this is an e antigen negative patient if you pay close attention to the subject line. And again, you have the purple, which is to treat. Clearly, if the ALT is about twice the upper limit and DNA is more than 2,000 in this case, you actually will consider treating this individual. If the ALT is elevated but not twice the upper limit of normal, this is a patient you want to monitor very closely. And if the ALT is normal, and if the BDNA is less than 2,000, this patient may not be treated, and you actually look for any other cause to treat, and you basically also follow these patients closely. So why not treat every patient? Well, in an ideal world, you should. One of my mentors used to say, if you see a virus, kill it, right? So antiviral therapies are easy these days, and especially hepatitis B. But this may not be practical because hepatitis B, this is a lifelong commitment, okay? Limitations of the therapies for hepatitis B includes this does not eradicate the infection. We can control the infection, but it doesn't result in cure necessarily. lifelong or long-term treatment is needed in most individuals, and there is a cost-benefit ratio which is not very favorable. Okay, so patients need to come, pick up their medications. You know, the insurance has to stay the same. Sometimes as insurance changes, the copay for these patients may actually be very variable every year, and those all factor in compliance when the patient will be on antiviral therapy. And if the patient doesn't take the medications, or if the patient only has a second line or a third line agents, then these individuals are also at risk for drug resistance. Okay, and very commonly seen is lamivudine resistance. We're going to talk about it in the next few slides. So when we're talking about monitoring of the patients, if we're looking at patients with e antigen positive chronic hepatitis B, as long as these patients are less than 30 and their ALT is normal, we can follow these patients every 6 months. Typically, we require ALT, hepatitis B DNA, surface antigen, and surface antibody. We do assess for liver fibrosis at baseline, and depending on that, we can monitor the fibrosis every year. This can be done using a fibroscan or any of the non-invasive tests, including a serologic test. And again, these patients should be screened for HCC as they are at risk for HCC. E antigen negative patients, when the DNA is less than 2,000 and they don't meet the criteria, again, they need to be followed. E antigen negative patients, again, when we're talking about DNA more than 2,000 and ALT is normal, they are in the immunotolerant phase. These are the group of patients we need to follow up closely with liver enzymes and hepatitis B panel. When we talk about antiviral therapies, there are 3 varieties or 3 classes of drugs. One is the nucleoside analog, and the most common one you see is the entecavir, lamivudine. Tilbuvudine and emtricitabine are actually the older medications, and emtricitabine by itself is not effective. It is going to be used along with tenofovir. When we talk about nucleotide analogs, these are tenofovir disoproxyl fumarate and tenofovir alafenamide, which is TDF and TAF, and adafovir. Now, all the medications in the green are your first-line agents because their drug resistance is very, very low. And when you talk about immune modulator therapies, these are your interferons. The first one is a pegylated interferon, also called Pegasus, and the other one is interferon alpha, which is intron A, which is given at least 3 times a week. So Pegasus is given once a week, interferon alpha is given 3 times a week. So how do we decide which drugs are first line and which drugs are second line? Again, all the medications highlighted in green in the previous slide are your first line. And the reason for that is their resistance rate is very low. It's between 0 to 1.2%. Tenofovir, we do have experience with tenofovir for almost 10 years now. We haven't seen hepatitis B drug resistance to tenofovir. Whereas if you look at the third line therapy, which is lamivudine, the resistance rates are alarmingly high at about 75%. So please, if you want to treat a patient for hepatitis B, do not use third line therapy at all. Second line therapies, a word of caution about second line therapies is adafovir and tilbuvudine. During the first year, the resistance is not that much of an issue. They're very effective drugs, but as you continue the patients on second and third year, their resistance rates can go up to almost 25%. So again, they are your second line therapies. Now, when do you think of using oral medications versus injectable medications? The pros for oral medications are they're simple. They're given orally, so they're well tolerated, and these medications can actually give rise to maintained response, meaning as long as you take the medication, you actually can control the virus. The pros for injectable is you can give this medication injectable for 6 months to a year, you can actually get a sustained response, meaning once you withdraw the drug, you can see that the effect of drug can last for several years. And again, it works on your immunity, so there is no obvious resistance. What are some of the disadvantages? Well, with the oral therapies, resistance duration, typically it's given for long-term. And long-term safety, this is especially true for TDF. We're seeing some renal toxicity and bone health being some of the issues with long-term use of TDF. And those disadvantages are not going to be there with the interferon. But one of the disadvantages is it's an injectable, so you need to inject subcutaneously. There are a lot of side effects with interferon-based treatments. Most people can get flu-like symptoms, and that can be unbearable. And many of them can also not go to work and seek absenteeism, and other kinds of economic factors also play in. Now, when you look at contraindications, interferon is contraindicated in pregnancy, it's contraindicated in decompensated cirrhotics, post-transplant, and also in patients who have a very severe flare. Okay, so you can't give interferon in them. So how these medications work, this is kind of a graph. So if you look at these two lines, the darker line is hepatitis B DNA, and the gray line, or the gray square, is the hepatitis B surface antigen. So even if DNA is suppressed, surface antigen tells you how is the activity of hepatitis B within the liver. Okay, so this is a trial which was done using interferon, and you can see that both DNA and activity of hepatitis B within the liver are both reduced. Now, when you stop the treatment, which is end of treatment, you can see both of them actually going up again. Now, when you use interferon plus lamivudine, again, this was a historic trial where we thought, well, why don't we give interferon first, 6 months, and then add an oral therapy? Again, as long as they get both, surface antigen becomes low and DNA also becomes low. And when there is end of treatment, both of them actually go back up. But when you do only oral therapies, this is lamivudine, you can suppress the virus, which is the black square. So clearly it has antiviral activity, but what happens within the liver? So you don't see that much of an intrahepatic response for hepatitis B. So again, which tells us that interferon has an additional role in controlling the hepatitis B replication. And this actually brings us to the next slide, where we're looking at efficacy of these treatments. So with suppression of DNA, the oral medications will do really well. If you look at TDF, if you look at entecavir, lamivudine, telbivudine, the rate of DNA suppression is anywhere between 36 to 76%. But if you look at the rate of suppression of DNA in the interferon group, this is the first column, you'll see that the response is only up to 10%. Now, the opposite is true. If you're looking at e antigen seroconversion, this is more immunogenic way of controlling hepatitis B. The seroconversion rates are much, much higher with interferon, which can be almost up to 35%. 1/3 of the patients can develop e antigen seroconversion with just a finite course of 6 to 12 months. Now, even if you give them lifelong, you can only expect 20% or so or less response with the oral antivirals. Even when you look at the most rare happening, which is hepatitis B surface antigen loss, you can see that the rates with interferon are much higher, 3 to 7%. Compare that to the orals, it's barely between 0 to 3%. Okay, so again, this kind of highlights that interferon-based therapies could be effective in hepatitis B patients. Now, this is the same in hepatitis B e antigen negative patients. Looking at the viral load, much, much effective viral suppression with oral medications. It can go all the way up to 93%, whereas with interferon, it's only 19%. But if you look at surface antigen loss, you can expect 4%, but it's almost infrequent. It's 0% with any of the oral therapies at the end of 1 year. So going to the next slide, we did mention about entecavir, TDF, and TAF as first-line agents. So out of all three, if you give TDF long-term, it can cause problems. So when is TDF less preferable? So if you're thinking of treating a patient over age 60, we think that these individuals also have bone disease. And if you have chronic steroid use in the past, or osteoporosis, or if you're treating a postmenopausal woman, that woman is at high risk for osteoporosis. So TDF will increase that risk for osteoporosis. So that is a group you probably will think of using the other medications. And again, renal disease. So anyone with CKD, typically GFR less than 60, or if you're seeing albumin in the urine, and this can be easily done using a dipstick at your offices, or if you're seeing low phosphate levels. Again, this is the reason why most people get osteoporosis, or if the patient is on hemodialysis, again, you would tend to use TDF less, or you should renally adjust the TDF dose. But the other options will be you can use entecavir or TAF. Now, these are some of the other things you need to do while you're counseling patients on hepatitis B therapy. Remember that when you're treating a patient with hepatitis B, that's not the only thing that may be going on with the patient. The patient may be drinking alcohol. The patient may be smoking heavily. The patient may have risk for fatty liver and NASH. So we should try to mitigate whether the patient is on treatment or whether the patient is off treatment. We need to control all the other modifiable risks, okay? So metabolic risk factors needs to be counseled. Patients with steatosis, obesity, and diabetes, all of them have shown that there is increased risk for liver cancer, and there's also increased risk for fibrosis and progression to cirrhosis. So again, whether or not you're treating the patient for hepatitis B, these other things need to be discussed, assessed, and counseled. So if you think of starting a patient on hepatitis B treatment, the recommendations will be you monitor these patients, checking for ALT and DNA periodically, at least every 6 months. If the patient is on TDF especially, this is a patient who is also at risk for CKD and bone health being compromised. So we should actually do an assessment for renal disease. We measure the GFR and serum phosphate levels every 6 months. Remember, again, all these patients should get screening for HCC, okay, despite treatment. And there are scores where we can actually measure what is the risk for HCC. And I personally don't use the scores that much, but as a rule, HCC screening must be done in patients with or without treatment. When to stop therapy? Generally, again, when we talk to the patients, we should counsel them that these patients should require indefinite treatment. Okay, this is lifelong therapy. The oral medications can be discontinued, especially if the individual gets hepatitis B surface antigen. Okay, so if the patient has a seroconversion and surface antigen is lost and surface antibody is positive, this patient should be can come off the treatment after a consolidation period of 6 to 12 months. Now, in e antigen positive patients without cirrhosis, if again you can see e antigen seroconversion happening and B DNA is completely undetectable, these patients can come off of treatment after a year of consolidation therapy. Again, when they come off of the treatment, these patients need to be monitored. Okay, again, ALT, DNA, and liver cancer screening must be done. In e antigen negative patients, again, if the patient doesn't have cirrhosis, these patients also, when they achieve virologic suppression for more than 3 years, And if they develop surface antibody, preferably, these are the patients who can actually come off of the treatment. So going back to our resistance slide, if you look at the cumulative incidence of hepatitis B with oral medications, like I said, we have up to 10 years data now. Okay, this graph only shows 5 years. This was presented in 2017. TAF, which is a recent molecule, we don't have experience for 2 years or more. So you can see that TAF doesn't have any resistance, TDF doesn't have any resistance. And entecavir, in the first 2 years, the resistance rate is less than 0.5%, but in the subsequent years, as the patient remains on treatment, the resistance can go up to 1.2%. Telbivudine and adefovir, as you can see, during the first year, the rates are low. But as the patient continues treatment during the second, third, fourth, and fifth, that resistance can go up to 20 to 29%. Whereas with lamivudine, even the first year resistance rate is almost as close to 25% or more. So we're not going to quiz you on the resistance variance, but this is just present in your syllabus about all these varieties of mutations that can result with resistance to lamivudine, telbivudine, TDF, adefovir, and TAF. Okay, so as you can see, there are no resistance mutations for TDF or TAF, which is possibly the reason why we don't see much resistance with that. Even with these A181 and N236 mutation, you can still see that these medications have a good susceptibility. So if you're thinking of checking for resistance, this is some of the slides that can help you figure out what you can do. And if you see that the patient may have A181 or N236, and if the patient has positive viral load and you don't want to see any positive viral load, you can actually add emtricitabine to TDF, and that will be basically 1 pill once a day for these patients with positive viral loads. So how do you manage patients who develop resistance? Clearly, I mean, there are only 3 first-line therapies. If you're seeing lamivudine resistance, we need to switch to one of the tenofovir. Okay, we don't want to give entecavir to a patient with lamivudine because they belong to the same class. If it is telbivudine resistance or entecavir resistance, we clearly want to switch them to TDF or TAF again. Okay, because these are the molecules with 0 resistance. The only time you can think of entecavir is if the patient has adefovir resistance, which is nucleotide, so it's a different class. So if the patient is lamivudine naive, you can switch them to entecavir or any of the tenofovir compounds. But if the patient has exposure to prior lamivudine, you can give tenofovir again, and this is a patient where you better give one of the tenofovirs. And again, if the hepatitis B DNA doesn't completely go down or doesn't become undetectable, you can think of adding entecavir or switch to entecavir along with adefovir, but I would go with one of the easier options, which is use TDF or TAF. Now, when you have TDF or TAF resistance, which is again, in theory, not possible, we can add entecavir to these patients, or we can simply do emtricitabine plus TDF or TAF. So coming back to our patient, again, this is our same patient. Now you did serologies and the first part, which is the same, but on follow-up, she has hepatitis B DNA in almost 800,000, and now the ALT is 44. So this is a patient where, there is inflammatory activity within the liver. This is measured by the ALT. And also the DNA is almost close to 1 million. So this is a patient, again, you do the initial assessment with FibroScan, and she is now showing that she has immunoclearance or immunoactive phase, and she should be considered for treatment. Okay, so HCC surveillance, again, the first line is very important. Even if the patient doesn't have cirrhosis, she's at risk for hepatocellular carcinoma. We have to remember that this is a class 1 carcinogen, so it causes cancer. It's highly oncogenic virus. And the cause of that is, we know that the genome, the hepatitis B genome, incorporates itself into the host gene, and it actually causes cancer-related genes to basically get stimulated and causes liver cancer. Okay, so again, in a patient with high risk for HCC, the cost effectiveness to the number of years gained, I think these patients should be treated, and we can prevent cancers. According to the AASLD guidelines, in a non-cirrhotic patient, all hepatitis B carriers at high risk, such as African American or Black men or Asian over 40, or Asian women after 50 years of age, they are considered to be at higher risk. First degree relative of a patient with HCC, or any carrier over 40 years of age with persistent elevation of ALT and a DNA level more than 2000. These are considered high risk for HCC, and these patients should be treated. If the patient doesn't want to be treated, whether you're treating or not, they still should get HCC screening. You should consider at least an ultrasound. Now, alpha-fetoprotein, this is a typical blood test. This can be done with or without scans every 6 months. So this is again the 2017 cirrhosis guidelines. AASLD recommends surveillance of adults with cirrhosis because if you identify patients with HCC and you refer them to local regional therapy or even liver transplant, you actually can improve overall survival. So, any questions so far from the group? I'm going to give a few more minutes. We still have 10 minutes of time, so. Okay, so again, I urge you to post questions. If you don't want to unmute yourself, you can actually put it in the chat. Okay.
And yeah, you guys can put it in the chat. This is Rachel, but the name is coming up as Cade. Kind of reverse. Cade is showing up as Rachel, or you can put it into the everything chat.
Yes. Okay, so going on with our talk, this is about hepatitis B cure as our future objective. Clearly, again, to achieve hepatitis B cure, we need to screen patients, we need to diagnose hepatitis B appropriately, and we need to prevent the transmission of hepatitis B. So these things need to be done. Okay, but what is in the pipeline? So we do have new biomarkers. We have cccDNA, we have hepatitis B core antigen, we also have hepatitis B RNA. So some of these biomarkers actually tell us about how eradication of hepatitis B from the liver is going to be achievable, okay? So a lot of the trials are going on looking at these specific biomarkers which tell us about hepatitis B eradication. And again, we also have several direct-acting antivirals and immunotherapeutic agents. A lot of them are in the preclinical and animal studies, but they show good promise. And like I showed you in the first slide, in our first module, that there are several steps in the life cycle of hepatitis B where it can be interrupted and the life cycle can be inhibited. So future options also, we need to consider about eradicating hepatitis delta. And again, we do have interferon-based therapies. We also have interferon plus oral agents which are available to treat hepatitis delta. So this is to show you again the several steps in the eradication for hepatitis B. So there are entry inhibitors, which are labeled as number 1, capsid inhibitors, these are number 2, inhibitors of cccDNA, inhibitors of transcription, and again there are 9 to 10 different steps at which the hepatitis B, from the time of entry into the liver cell to the time of exit outside the liver cell, all these steps can be blocked with the newer molecules that are being tested. And again, this is to show you all the newer medications that are currently being investigated, of which I can tell you that, remember from the previous slide, there is a ABI in the first column, ABI HO731. So this is a molecule that was recently presented in the European Liver Meeting in April 2019. There are 2 phase 2 studies, and this is a core protein inhibitor. It's a small molecule. So again, this molecule inhibits the hepatitis B life cycle at several steps. This has additional antiviral activity compared to the ones that we already have. So this can actually lead to a functional cure where it can get rid of the virus, but it also can get rid of the antigen. So this is the intrahepatic activity of hepatitis B. And it has a potential role to eliminate cccDNA, which means if we eliminate cccDNA, there is a lower risk for liver cancer.